Hello and welcome to a Royal New Zealand College of Urgent Care CME podcast interview. My name is Guy Melrose and today we are talking with Dr Justin Morgenstern about whether IV antibiotics are superior to oral antibiotics when treating cellulitis. So I'd like to welcome Justin Morgenstern to the Royal New Zealand College of Urgent Care's podcast. Justin is a Canadian who is in New Zealand for a year, working down in the Taranaki Base Hospital and the Hawera Rural Hospital. He is an emergency-trained and family practice-trained physician from Canada, and he's kindly agreed to talk with us today because we discovered him through his blog, The First 10 EM, which there'll be a link to in the show notes. Which covers a lot of topics relevant to emergency medicine and also urgent care. So welcome, Justin, and thank you for talking to us today.
Yeah, thank you so much for having me. I'm looking forward to our chat.
So we looked through your blog, and there's a number of things there that we could talk about, but one that we agreed was very relevant to urgent care practice here in New Zealand is your dive that you went into looking at IV antibiotics for cellulitis. And are they better or worse than oral antibiotics? And you went through the data, you went through the studies, and you came to some interesting conclusions. So IV antibiotics in New Zealand are used in the community as a protocol, usually as cefazolin with probenecid, and the protocol is designed to keep people out of hospitals, which is an important part of urgent care practice. But there might not be the need to go as far as IV antibiotics in treating these cellulitises. So let's start at the beginning. And the patient expectation and the doctor's expectation is that IV antibiotics are stronger and therefore they work better. But your feeling is that the bugs don't really know what route the antibiotic entered the body.
Yeah, this one is a fascinating one. I love this topic a lot because unfortunately it's one of those areas where even though we're all on the same team, we all want the absolute best for our patients, it does end up with some conflict sometimes between the emergency department and GPs and urgent care, often because a patient will be sent in saying this patient needs IV antibiotics, and I'll send them back saying, nah, they don't. And so this, for me, goes all the way back to medical school and just sort of basically thinking through this. I saw a lot of IV antibiotics being used. This happens in Canada as well, and I think around the world, for patients to me who looked quite well, who could swallow their pills. And, you know, maybe it's because I took microbiology courses all the way from high school, but I was just thinking about it, and it just doesn't make any sense from a basic scientific level, right? You have a little bacteria floating around down by your foot, a little strep or a little staph down there, and there's an antibiotic chemical that's going to make it down to the skin of your leg, but the bacteria and the antibiotic chemical have no idea whether it entered your body through an IV or whether it entered your body through a stomach. It doesn't make any difference at all as long as the antibiotic is making it down to the area where the bacteria is. And so seeing as we know that these are antibiotics that people can swallow and can get absorbed, there's just always a fundamental gap that even though people seem to have this idea, there's this frame that antibiotics by IV are stronger, IV is better. It never actually made a lot of sense to me right at the baseline.
And this has a basis in bioavailability of the antibiotics that we give, that most of the antibiotics that we would use for cellulitis, the oral ones, have pretty good bioavailability. So there shouldn't be a concern about getting the concentrations up.
Yeah, I put a chart in my post on the blog post here. Most people for cellulitis would be using something like cefalexin, which is 90 to 100% bioavailable. Clindamycin is 90% bioavailable. Doxycycline is greater than 90% as long as you're taking it with food. And even if you're trying to cover MRSA, which isn't a big problem here, trimethoprim sulfamethoxazole, it's between 70 and 90%. So when you swallow these pills, the vast majority is absorbed. I will, as a side note, a little bit nerdy on bioavailability. Really, that number is just the percent that is absorbed into your bloodstream or into your system. So actually, the percent itself doesn't probably matter all that much. It's the concentration that's needed in the blood. So azithromycin, for example, has an awful bioavailability, something like 30%, but we use it all the time, or we used to until everything became resistant to it. And it worked great against pneumonia because you could swallow a gram, but you only actually need 250 milligrams in your blood. So even if you saw a low bioavailable number, it doesn't mean the antibiotic's not going to work, but when it's a high bioavailable number, we know for sure that everything you're swallowing is getting into your bloodstream, and it just should work.
So the reason to consider IVs over oral would be the patient can't physically take an oral dose. That's obviously one reason. What would be other reasons to actually that patients would be put onto IVs?
Yeah, so I have a relatively short list. I mean, there's the obvious. If somebody is critically ill with necrotizing fasciitis and 20 minutes is going to make a difference because there is an absorption time through the stomach, clearly we'll give it an IV. Let's get it in 20 minutes quicker. That's a pretty rare case, and in an urgent care, in a lot of settings, actually, by the time you start an IV, you might as well have just swallowed the pill from the beginning. There are a lot of syndromes where you're not going to absorb very well through the gut. So, if somebody had a short gut syndrome or some kind of significant GI problem, these bioavailability numbers may not apply very much. The one that we tend to overlook. So obviously, most people are going to use IV antibiotics in sepsis. And I don't actually think that it's the fact that they're septic that means that you need IV. But when you have low perfusion to the rest of your body, you're probably not perfusing your gut, and so you're not going to absorb the medication very well. So in a shock state, in a low perfusion state, that's another time that I would consider switching to IV instead of PO. And then the weird one that we may be getting into more and more, I've heard it more out of America, where you're going to see a lot more obesity than both in Canada and New Zealand. But there's a lot of pharmacists who are really strongly recommend that all antibiotics should be weight-based dosing. And so as you start to get bigger and bigger individuals, you need larger and larger doses of antibiotics, and sometimes they just can't tolerate those. You start vomiting if you give people too much of certain antibiotics. So that's sort of my list that I would go through my head on when I might want to use an IV. But those are rare patients. I tell you that in a year treating cellulitis in an emergency department, I probably use IV 1 or 2 times.
That's fascinating. And I think the next question after that has to be, is there evidence to support your practice then? Like, can we use any studies to support that stance?
Yeah, it's a really good question, because everything we've been talking about so far is just physiologic reasoning. And if you read through my blog, you'll see that I'm a bit contrary on physiologic reasoning a lot, because it's led us astray many, many times in the past. Just because something should work in the human physiology doesn't mean that it always works. This is not the strongest area of evidence in all of medicine, but actually, when you compare it to a lot of our practices, it's not that bad. We have 4 randomized controlled trials to guide us. 3 of them are old and use antibiotics that we don't necessarily use, but I still think they give us some pretty good hints. And 1 is actually a really good RCT that is basically exactly the practice that I think that we would be looking at. But then we'll be basing our practice on 1 RCT. And then at the very end, we can probably discuss a little bit. There's a ton of other trials comparing IV and PO not in cellulitis. And that can at least give us some hints about the difference between IV and PO. So that's sort of the fundamental basis. And because there's only 4, maybe we just want to go through and chat a little bit about each one.
Yeah. If we start with the first one on your blog list, that was the oral versus parenteral antibiotics for the treatment of cellulitis, randomized non-inferiority trial from the Journal of Antimicrobial Chemotherapy 2015.
Yeah, so this is the one that you're really going to want to focus on, because this is the modern study. This is the one that really asks the question that we want answered, because this trial took patients where an emergency physician already thought that IV antibiotics were needed. So they had been assessed by the emergency physician. They were either febrile. Most of these patients had already been on antibiotics for a few days and they weren't getting better, but that was about half the group. And so the clinical judgment of the physician examining the patient was, IV antibiotics are absolutely needed. So they sent them over to the IV antibiotic clinic, and at that point, they randomized them to either PO or IV. So that's the perfect trial. That's exactly what we want to know. The patients that we think need IV, do they really need an IV? They're using the sort of antibiotics that I would use in Canada, and it sounds like people would use here. So if you were in the oral group, you would get a gram of cefalexin 4 times a day. And I'll say a lot of people use that at 500 4 times a day. I've always used it as a gram in Canada. I think you can go slightly higher in dose. That might be a little pearl. And IV was cefazolin 2 grams twice a day. So a little bit different than the New Zealand practice, but basically the same coverage, the same kind of antibiotics that we would use here. The oral antibiotic groups were given for about 10 days, or sorry, I should say the oral antibiotics were given for 10 days. The IV antibiotics were given until the cellulitis was no longer progressing, until it wasn't getting any bigger, and then you could switch the person back over to oral. And the quick bottom line summary, I'll say it's not a very big study. There's only 47 patients, but the primary outcome is there was no difference at all between the two groups. And in fact, if you dig in a little bit, the time it took for the cellulitis to stop advancing was 1.3 days in the oral group and 1.8 days in the IV group. So it was a half a day longer in the IV group. Now, this was a non-inferiority trial, and they were able to do the stats that says, for sure, oral antibiotics are non-inferior to IV. Then they flipped it over and they tried to do one of those superiority trials where was the oral group actually better, and it was just barely crossed that confidence interval. So unfortunately, you can't say that PO is better based on this study, although if you look at the 99% confidence intervals, it looks very likely like oral could be better, but definitely oral is no worse than IV.
And that's fascinating, because a lot of times people will, particularly with the community cellulitis protocol, they'll have the IV for a day, a second day, a third day, and then they're discharged with oral antibiotics to continue the course, if you like. And so patients have maybe got this idea that they've come in for the stronger IV dose to get on top of the infection, and then they're going back to the oral to finish the job off, when actually the time to no further advancement there was the same. It was better with the oral than the IVs. So that kind of contradicts a lot of the theory, or a lot of the perceived wisdom in why we're giving these people IVs in the community.
Absolutely. And I think there's one other really important pearl to pull out of the study, because I'll admit this is only 47 patients. So if you wanted to come, and also because of the IV in place, this is not a blinded trial. So if you really wanted to nitpick this trial, you could. But forget about that for a moment and just look at the outcomes. So in the IV group, the cellulitis was still advancing up to 1.8 days later. Think about what we do when we manage cellulitis. We bring people back at 24 hours or sometimes even 12 hours. And then when the cellulitis is advancing, we say, oh my God, the oral antibiotics aren't working, and we switch them over to IV. And these are patients who have already been treated for 3 or 4 days with oral antibiotics. So what this tells us is that the natural history of cellulitis, even when it's getting better, because all these patients got better, is for the cellulitis, or at least the redness, to advance, for to progress for at least 1.8 days, but these patients had already been treated for a few days. So for 2 to 3 days, we should expect the cellulitis to actually look like it's getting worse, even though these patients are getting better. And I think that's a huge pearl, because that's one of the things that makes us to change our plan. I know one of the biggest researchers in skin and soft tissue infections in the world is a guy named Greg Moran out of Los Angeles, and he's done all the studies recently on, should you use antibiotics in abscesses? And in all of their studies, at 3 days, at 72 hours, they allow the cellulitis to be increased by 25%, and they still call that getting better. Probably the bacteria are dying off and your inflammatory response is just going, or gravity is causing the edema to stretch. I'm not entirely sure, but the natural history of cellulitis is for it to get bigger even when you're getting better.
And that blows my mind to hearing that, because one of the when you look at BPAC, the cellulitis article from 2015, they say when to consider community-based IV treatment is has not responded satisfactorily to oral antibiotics. And as you say, we're not often doing that at 24 hours. We've done a little circle around the redness. We've told the patient watch for any worsening, and then if it's spread a little bit, then it's not getting better, so we go to IVs. But if 25% is the cutoff for spreading when it's actually getting better, then that changes a huge amount of how we have to look at these things, and the time frame in which we monitor these things. Of interest also was that there were no difference in complications in that study. From the point of view of IVs versus orals, IV would have more complications through the act of actually giving the antibiotic, regardless of complications of worsening infection, etc. But in terms of the act of giving somebody IV antibiotics has effects on the body from diarrhea-related things. And so what are the complications that you would be concerned about in giving somebody an IV antibiotic?
Yeah. It's a great question. And this trial only had 47 patients. And it's one of those big things, major lessons in evidence-based medicine, is that our RCTs often don't catch the harms. You have to look at bigger observational data. There was a really great study looking back, I think Heron 2014. It was an emergency department-based study, and they looked at all the groups of patients. So not just cellulitis, but pyelonephritis, a bunch of great patients where we considered giving an IV dose before they went home and then just switching them back to oral. And that single dose of IV antibiotics significantly increased diarrhea and C. diff, just one single dose. So that's a problem. There's a bunch of other little harms you can get with the IV, mostly local stuff, phlebitis, thrombitis, the extravasation and the IV coming out and having to come back in and replace the IV, local infections there. Those are all, relatively rare, except for the IV coming out. That happens all the time. And, as a physician, that's not a major harm, but for the patient who has to keep coming back in and getting poked, they might tell us that it's a bigger harm than we give it. But things like catheter infections and bacteremia are rare, but they still happen in literature somewhere between 1 and 2 cases for every 1,000 days that an IV is in place. And if you're getting no benefit at all, even though the harm is small, it's pure harm. So I think we do need to consider that small harm of infections and clots. And then there's probably the bigger harm, which is the societal harm and the harm to the patient, right? It costs a lot to take time off work and come in and get IV antibiotics, to sit in a waiting room, to be attached to these things for multiple days. I wouldn't volunteer to get IV antibiotics if I had any other option personally.
Yeah, and then there's the cost on top of that, both to the patient in terms of travel, but also the cost of the community centres or the EDs. Putting in IVs takes time. The equipment and the giving sets and everything takes time. If they could be at home or at work with a pot of pills, then that reduces so many different factors that we maybe don't think about when we're just thinking, oh, that redness has got worse, let's stick you onto IVs and you'll be fine. So yeah, that's the main study, that one that, like you say, has its problems, but it certainly is significant, and it's definitely worth reading. The next study that you listed was the one from the BMJ in 2002, oral pristinamycin versus standard penicillin regimen to treat erysipelas in adults, a randomized non-inferiority open trial. What did this one show?
Yeah, so this is a fairly big multi-center trial. It was 22 different hospitals in France. It specifically, instead of cellulitis, erysipelas. I don't think in our clinical practice that makes as big a difference. I think in other practice settings they're a little bit more picky about whether they're calling this erysipelas with that well-defined edge versus cellulitis. I will say that these are sick patients, so everybody here had to have fever, chills, and everybody here was actually admitted to the hospital, and then they randomized them again to either oral or IV antibiotics. This is the beginning of the older trial, so they're using things that I've never heard of. So the oral group was pristinamycin, a gram, 3 IDs, TID, sorry. And I guess the IV group was just penicillin, 18 million units divided into 6 infusions over the day. So that seems relatively reasonable. And again, this is a bigger trial, so 289 patients. And once again, the oral group was no worse than the IV antibiotics. And again, that's just statistically speaking, because if you look at the actual cure rate, the cure rate was 81% with oral treatment and 67% with IV antibiotics. In this group, everybody was in the hospital, and there actually wasn't a difference in the length of time they kept them in hospital. So they both stayed there for a very long period of time, 11 days in hospital, which seems crazy to me. But even though the cure rate looked like a little bit better in the oral group, in this trial, there were more GI side effects. You're going to have some more nausea and GI upset when you use an oral antibiotic as compared to IV. Relatively minor side effects in this one.
But ultimately, it didn't show a benefit. In fact, 67% versus 81% cure rate is reasonably significant. And again, like you say, that there aren't a huge amount of studies, but they're supporting the physiology and the kind of the logical scientific conclusions. They're at least supporting those. Do you think there's a reason why there hasn't been more studies on this? Is it specifically for cellulitis?
Yeah, it's a fascinating question. I think a lot of it has to do with just the way we fund research in general in medicine. Nobody's making money off of this. And in fact, it's the exact opposite. It'd be so much cheaper to put everybody on oral antibiotics. So the only people who would be interested in funding this is, I guess, governments, which unfortunately don't fund enough of our research. Most of our research is done by somebody with a vested interest who's actually selling us the drug. And so I think that's probably the big reason that we aren't seeing it, because this has the potential to make a big difference to both patients and healthcare systems across the world. It seems like a very obvious thing to study.
Yeah, it seems like the people who would be benefiting are the health systems that are paying all the money to be administering these medications. So maybe they should be the ones looking into it, because the next study that you listed was from 1992, which is that's getting back there into the dim and distant past, and that was again in the BMJ. The British Journal of Dermatology, and that was roxithromycin versus penicillin in the treatment of erysipelas in adults, a comparative study.
And it's actually the same first author as the one we just talked about a decade later. So I can imagine him just banging his head against the wall, being like, "My people don't understand this." So it's another multi-center trial, a little bit smaller this time. There's only 72 patients in it. Slightly different drugs. They use roxithromycin for oral treatment, and again, penicillin IV. This trial didn't actually tell us what their primary outcome is, but again, the results are basically the same. They're not a perfect trial in any way, because none of these are blinded. You don't blind whether it's an IV in somebody, but the IV group definitely was not better than the oral group. And that's all you can say statistically, because the p-value is 0.4, like it's not even close. But again, if you just look at the numbers, 84% cure rate with the oral group, 76% with the IV group. So it just, all the numbers seem to add up as if oral group actually looks better. And I can't really explain why that is, but in every trial so far, the numbers seem to favor the PO group.
So this chap Bernard must have been, like you say, questioning why 10 years later he was repeating, albeit with different antibiotics, repeating the same sort of thing and going, hello, 10 years, nothing has changed. Because then the final study from your list is from 1984, the journal Infection, the course, costs and complications of oral versus IV penicillin therapy for erysipelas. 1984. I mean, we're really getting back in the dim and distant past.
Yeah, and I think, again, none of these trials are perfect. This is single center and, again, not blinded. But I think the thing that really jumps out about these trials is these days we tend to use IV antibiotics if that redness is getting worse. But you absolutely assume that oral antibiotics could never be used for a sick or septic patient. But in these trials, you were actually excluded if you had a temperature less than 38.5 degrees Celsius. So you had to be admitted and you had to be sick with a high fever, and then they randomized you to IV or oral. The groups are a little bit different here because they did some combinations. There's 4 different groups. So you either got oral penicillin alone, or you got oral penicillin plus flucloxacillin, and then the IV was IV penicillin alone or IV penicillin plus cloxacillin in various dosing strategies. And they had a strategy if anybody ended up being allergic to penicillin, but actually nobody ended up being allergic. And it was, again, I said a small trial. I think 73 patients here. And once again, the IV was not better than the oral. The mean time till the fever went away was 2 days with oral treatment, 3 days with IV. Hospital stay was 5 days if you were on PO and 6 days with IV. You took 13 days off work if you were in the oral group as compared to 16 days with the IV group, and you had a recurrence rate of 11% with the oral group and 16% with the IV group. And maybe the most striking number, it's actually overall really cheap. The cost daily was only $2 in the oral group and $27 in the IV group. But if you did it in relative terms, that's a huge increase. So all those numbers are small and not statistically different except for the cost and days in hospital. But again, all the numbers are on the side of PO being better. And I think we can just skip ahead. Before the most recent study, the modern study came out, there was actually a Cochrane meta-analysis in 2010 that combined these 3 older trials, the 2 Bernard papers and this most recent trial. And the review of the conclusion of the Cochrane review was actually, when you put all these numbers together, that oral is statistically better than IV. You get better outcomes when you use PO drugs than when you use IV.
So again, all this information, all this data, all this sort of logic is all coming to one conclusion here. Now you've referenced a load of other papers, because we've only got 4 here for the cellulitis, but this supports multiple different types of infection. But the only one that we have a protocol for in the community, so the only one that would really affect urgent care would be the IV cellulitis protocol. But people can look into, obviously, pneumonia treatments, but we wouldn't be doing that in the community. We would be referring those in. But to give
but I think it's a good idea to know the papers, because it just supports the logic. Basically, I've searched far and wide, and every single trial that has ever compared IV to PO, including sick patients, pneumonia and pyelonephritis and endocarditis and osteomyelitis and febrile neutropenia, in every single trial, there's not a single trial that has shown IV is better than PO. Is the bottom line, which I think supports, even though they're not specific cellulitis trials, it gives me a better feeling that we're probably not missing something. It's probably true that just going straight back to our medical school thinking, and all we have to do is get that antibiotic down to the leg. It doesn't matter whether it's coming in through an IV or the stomach. It's probably correct.
So yeah, like you said, it all supports the evidence, and the logic all seems to come together here. And obviously patients who go into hospital are more likely to be sick and maybe not able to tolerate fluids, and that is certainly one reason why we would be referring a patient in who is unwell, who is septic, who there are concerns about the general health, and that's the reason we would be referring them in. But the patients who we keep out of hospital are given, in New Zealand at least, cefazolin 2 grams IV once a day with probenecid. And probenecid's an interesting one I just wanted to raise with you, because the logic for using probenecid is to enable that once a day dosing so that the patient isn't having to come back. But I have seen probenecid used alongside oral antibiotics. That would be presumably for the same reasons, but the advantage you have with oral antibiotics is that you can take more of them at home. You don't have to represent to a clinic to have the shot. What would be your thoughts on probenecid with oral antibiotics?
Yeah, the honest truth is I don't have a lot of experience. Probenecid is almost never used in Canada, but it doesn't make a lot of sense to me, because the whole logic of probenecid is it just stretches out the time in between doses, which is incredibly valuable when you're giving IV doses. But That's all it does. It doesn't make the antibiotics magically stronger. It just makes them last in your body for a longer period of time. And with oral antibiotics, I'm primarily using Keflexin. I prescribe it 4 times a day. I don't need it to last longer in the body. I don't think that there's a huge convenience factor from changing that 4 times a day into a twice a day kind of medicine. And adding extra medications, I always worry. I like to keep things simple and try to keep things to single medicine regimens as much as I can in life.
Yeah, and certainly the BPAC article from 2015 does say probenecids only to be used with the IV protocol. It's not necessary for the oral. So certainly for the New Zealand-based listeners, you don't need to be considering the probenecid with the orals. Now, we've touched on the harms of giving the IVs. I guess the next point I would like to ask you about is you mentioned at the beginning the reasons you would give IVs, and really there were quite a limited selection there. But what are the reasons why somebody might not be getting better? Which might make us think, oh, this isn't getting better, let's go to IVs. But are there other conditions or other situations where we have to actually stop and think, are we diagnosing, is our cellulitis diagnosis the problem? Are we actually misdiagnosing this person?
Yeah, and I think this comes up a lot. And I think it may be the most common reason for switching to IVs. So when I see somebody who isn't getting better on oral antibiotics, I really quickly ask myself 4 questions. So I ask myself, is this actually cellulitis? Could I be wrong? Could it be something else? I ask myself, is there an underlying abscess to the cellulitis? I ask myself, am I treating the right bacteria? Is there something not in the normal strep and staph range that I need to be thinking about? And then finally, I just ask, have I given this enough time? As I said, often these keep getting worse for 2 or 3 days. So I think each of those is probably worth chatting about just a little bit. I think maybe the most important question was that number 1, is this really cellulitis? I don't think we're as bad as there's a few recent papers. I think one that came out in the BMJ that said that emergency doctors were wrong 80% of the time when they diagnosed cellulitis based on biopsies that a dermatologist did down the road. I don't think that we're quite that bad, but I think anytime we see something hot and red, we just call it cellulitis. And I think it's important to realize that there's a fairly wide differential. I've definitely seen a large number of patients referred into the emergency department for IV antibiotics with bilateral leg cellulitis. And you really just can't get an infection simultaneously in both legs. That doesn't make sense. So that's going to be a venous stasis rash. So I'll tell you the things that I quickly go through in my list. So stasis rash is probably the most common, stasis dermatitis. And I think the key clues to that for me are that it's bilateral and that it tends to be really itchy. Another thing that I see a lot that unless you've seen it or unless you've looked it up, you will have seen it on a patient, but you may not know it because I didn't hear about it in medical school. It's something called lipodermatosclerosis. And honestly, the best way to do this is just type that into a Google image search, because as soon as you see the image, you'll be like, oh, I have seen that so many times, and I've tried to treat it with antibiotics, and the antibiotics won't work because this is a worsening of stasis dermatitis. So it's in patients who have that chronic venous insufficiency, and they get this very firm skin. So when you touch it, it feels a little bit like wood, and it's quite painful. And it tends to be in the area of the medial ankle. But this is a visual diagnosis. Just type lipodermatosclerosis into a Google image, and you'll make the diagnosis every time. A few other ones I have on my list. Contact dermatitis should be obvious, but just taking a step back from the patient and saying, is there a pattern here? Is there an exposure? And then the key question again, is it itchy? Because cellulitis shouldn't be itchy, but a lot of these other differentials will be. That's the same thing for a dermal hypersensitivity reaction. We've all had this. You get a bug bite, just a bad mosquito, and for whatever reason, that couple percent of the population, it gets really big, really red. But as compared to cellulitis, it tends to be more itchy than it is painful. So I'd say those are my 4 big ones. There's a few other ones you might think about, gout or erythema migrans. But when I look at that list, every time I think about cellulitis, there seems to be 2 big things that jump out at me at being a hint that something might not be cellulitis. And that tends to be itch, and it tends to be being on more than one area of the body. Cellulitis really should be in a single area because it is started because of a break in the skin, and it really shouldn't be super itchy, whereas other dermatology type things are. So that's my list. I'm sure I'm missing things because I am no dermatologist. Anything else that you're routinely looking for?
No, I think that's the first thing is to stop and think, and just don't blindly carry on down the cellulitis line just because the diagnosis was made, and particularly if you're the third or fourth person involved, you've got to. It's always good with any condition to take a step back and rethink it. Certainly something we see here a lot in New Zealand is the white-tailed spider bites and other little biting critters that get blamed for cellulitis, and a lot of the studies have shown that that's probably more of an inflammatory reaction, but people get put onto antibiotics for bites when actually it's the warmth and the redness isn't infection, it's more an inflammation. The thing that you mentioned before was abscesses, and that's an important thing to talk about, because if you don't treat the abscess, they're not going to necessarily respond to the antibiotics.
Yeah, that's absolutely the case. And unfortunately, a lot of the time people know there's an abscess there. And I think either because of the setup or how busy we are in clinic, or just because we're not comfortable with procedures, we try for antibiotics for a couple of days first and put off that procedure. And my general rule is if I see any pus, it's got to get drained, because abscesses just don't get better with antibiotics alone. With the exception of apparently peritonsillar abscesses. There's been a few studies recently where without drainage at all, some antibiotics, they've gotten better. But in general, we're talking skin. I'm draining the abscess as soon as I find it. It's getting a little bit easier now because some of these are subtle or they're deeper. So I don't know how many urgent care centers have an ultrasound machine in the emergency department. If there's a question, I just run the ultrasound over, and it's so easy to find an abscess that we've missed for a couple days.
So the answer to that question is not many, but it is certainly a growing area, and there's an urgent care physician in Wellington who is leading the way in terms of urgent care ultrasound. And watch this space; he'll be talking to us at some point in the future on ultrasounds. But yeah, certainly if you haven't got rid of that pus, then that patient's going to keep coming back. And like you say, it is a time thing. I think it is considered quicker just to ask the nurse, put a line in, give an IV shot, and off you go. And then it becomes somebody else's problem. And often, if you're not draining the abscess, you are creating a problem for somebody else further down the line. So, certainly. Then the other thing, from a patient expectation point of view, and coming here from Canada, you've mentioned that you're giving IV antibiotics once every so often, once in a blue moon, really. But also the patient might have been referred into your emergency department with the expectation of IV antibiotics. Have you found it difficult to overcome those expectations in patients? And is that probably what's driving a lot of our use?
So I haven't, but I tend to, a lot of things that other physicians have told me they have a lot of issues with, like not giving antibiotics for colds or not CTing heads. I just haven't seemed to had the same problems with. So I think a lot of these have to do with trying to find the right words and the ways to describe these to patients. I've had more a share of angry physicians, so people who have referred somebody in for IV antibiotics and I've sent them back not on IV antibiotics. But I'll tell you the truth, if a physician already has a plan in place, I don't overrule it without the patient being on board. But this is such an easy sell. I tell the patients that I've read all of this evidence. I basically tell them what we've been through today, and that actually things seem to get better when you use oral antibiotics than with IV. And so would you rather us poke you today and leave the IV in place for 3 days and have to come back to a nursing center once a day for the next 3 days, or would you rather just take these pills and go home? And so far in 8 years, I've had nobody say no to the pills-based approach. So I think it is some shared decision making. I think because it's so hard to overrule another doctor's plan, but I think it is fair, knowing the evidence and trying to do the best things for our patients, to discuss that with your patients. And I think if you start having this conversation, patients are pretty happy not to have the IV.
Certainly, and I would be. Hearing what you've said and reading your blog, I think I would definitely come to that conclusion myself. So how would you summarize this whole debate then, the IV versus oral for cellulitis? What would be your summary?
Yeah, I think very simplistically, the summary is PO is the way to go. As I say, it's so rare for me to use IV antibiotics now, and unfortunately, we don't have that single 10,000 person double-blinded randomized trial, so it hasn't made it into all the guidelines. But this is part of being a doctor, and if you just think back to what we know about basic biology, right from the very beginning, it doesn't make any sense that the IV is going to be any better or any stronger. And then all the studies that we have to support us all seem to support that conclusion that at worst, definitely oral is not any worse than an IV, but actually when you put them all together, it actually looks for some reason like oral tends to get better. So let's not get cavalier. Like we said at the beginning, if somebody's really sick, if this could be neck fash, if they might have shock and they're not perfusing their gut, if they have some kind of major GI problem, there's still going to be times when we need to use an IV. I'm so glad that we have the ability to cannulate our patients. But for the vast majority of cellulitis patients, you can use oral antibiotics. They will be grateful. The hospital will be grateful. Your emergency colleagues will be grateful, and life will be easier.
And if anyone's listened to this and it's piqued their interest and they want to dive a little bit deeper into this, fortunately, you've done a lot of the digging and a lot of the searching, and you've laid it out wonderfully in a very easy to read and yet very detailed blog. And moving on to your blog, the first 10 EM, there'll be a link in the show notes. What would you say about your blog? How did that start, and what can people get from it in addition to this topic?
Yeah, so it's a bit of a mix. It started in two different ways at the same time. And so part of it wouldn't be an urgent care-based blog. The idea of the name, First 10 EM, was when I was going through training, there wasn't a textbook that I really wanted, which was when somebody really sick comes in, when somebody's crashing, just something to tell you what to do in those first 10 minutes, because textbooks are always written around, MI or PE. But when a patient comes in, you don't know what it is. You just know that they have severe pain and they look like they're dying. So I was trying to write just basically my first 10-minute approach to some really sick patients. So that's half the blog. But at the same time, I've always been a big evidence-based medicine literature nerd. And so I was sending out sort of email summaries of evidence-based medicine to my group at the time. And so I just started putting them online as well. And actually over time, this has mostly morphed into an evidence-based medicine type site where I half the time just review one paper, and then I do some really deep dives into an entire topic, like, is stress testing of any value at all? Or like we talked about today, are IV antibiotics any better than PO? And so even though it's, I'm coming from an emergency medicine standpoint, I trained in emergency medicine and family medicine, and I'd say most of emergency medicine, at least 90% of emergency medicine, covers the same topics as urgent care. So I would hope that there's some useful stuff on there, or people would find it useful in your audience.
Certainly, I can highly recommend looking through. There's plenty on there that is very relevant, and the other stuff is interesting. And we have people who work in rural EDs and the like, and so they need that first 10-minute stuff as well. So it's definitely worth a look. It'll be linked in the show notes. So Justin, thank you for taking the time to talk to our podcast and go through this topic, and for doing all the legwork in terms of researching the evidence and coming up with such a clear conclusion and explaining it to us so clearly today. I look forward to talking with you again in the future, but for now, thank you very much for joining us.
Thank you so much for having me.
My thanks to Justin for talking to our podcast and providing a thorough, evidence-based review of this topic. I found talking to him and reading his blog has changed my perspective on treating cellulitis, so I'd be interested to hear your thoughts and feelings. Email podcast@rnzcuc.org.nz or leave a comment on our Facebook. Now make sure you listen to episode 10, also out today, in which we discuss this month's Urgent Bites, as well as this interview, and we look at recent urgent care relevant stories from the news. We'll be back with another CME podcast at the end of next month, and there will be an Urgent Bite, as always, every Friday in between. I look forward to seeing you all then, but for now, thanks for listening. The information discussed in this podcast was intended for the ongoing professional development of qualified health professionals and should not be used for self-diagnosis. For any personal medical concerns, please consult your usual doctor.